I was new to a home health agency, and I had just started as their director of nurses. And so I inherited the agency. And when you're new, you live with what was coming before as you're busy trying to improve things. And the surveyor walked in, and we ended up with several condition level deficiencies. Now they were right. There were issues that needed to be fixed. But then what I was able to do was to turn the agency around. And the next survey that came was 2 years later, and I'd been there for a while. And we went from condition level deficiencies to deficiency free surveys. And that was, but it was a lot of work. It was a lot of hard work. It was changing a lot of processes, letting some nurses go that just really could not come up to the standard of care that became the expectation for that. But it was a really good feeling to realize that we could, with a lot of hard work, go from an agency that had a lot of challenges to a deficiency-free survey agency.
Welcome back to Inside Home Health. I'm Arvind Sarin, and I am here with Kathy Ducket for session 7. Kathy, we've covered a lot of ground together: PDGM, referrals, documentation, staffing we did last time. Today, we're talking about something that every agency owner thinks about, but doesn't always understand it fully: quality ratings and surveys. If you go to Medicare Care Compare right now and look up home health agency, you'll see star ratings. And I think most people assume that's straightforward. 5 stars good, 2 stars bad. But when I started to dig into this, I realized that it's way more complicated than that. There are actually 2 different types of star ratings measuring completely different things. And behind those ratings is a survey process that can make or break the agency. So today I want to understand, what do these star ratings actually mean? How do surveys how do surveys actually work? And what happens when these things go wrong? Kathy, you've been through surveys, you've been through agency struggle with ratings. Let's get into it.
Okay. So the first question?
Yes. So when someone looks up a home health agency on Medicare Care Compare, they see star ratings, right? But there are actually 2 types of ratings. If we could tell our audience about, what each one measures and why they're different.
Yep. So you're absolutely right. There are 2 different star ratings. And when you see the review, when you go to Home Health Compare, you'll see a home health agency, Sarin VNA. So you'll see them, and then you'll see the quality star, and and you're right, it'll be a 1 to 5. And then below that, you'll see patient satisfaction stars or patient stars. And that's the same thing, 1 to 5. So let's start with the quality stars. What happens is that your agency is being measured on 7 quality related items. And what they do is they use the OASIS time points. So from start of care to discharge of care, how well did the patient improve in certain areas? And then they also use the patient or the Medicare billing data. So one of the things they look at is timely initiation of care. According to the regulations, you have 48 hours to admit the patient from the time you get the referral. So if the referral comes in on a Monday, you have to admit the patient on Wednesday. If you don't admit the patient on Wednesday, you must document why that didn't happen. And it can't be because you didn't have the staffing to do it. Medicare says
Friday to, is it Sunday?
Yes.
Oh
Yes.
my God.
That's why home health agencies work 7 days a week, right? Is that if you accept the patient, you recognize that you have 48 hours to get that done. You have 2 days.
What happens if you can't? What happens if it gets delayed?
So it depends on the reason. If the reason it's delayed is because the doctor has said specifically, I want the referral to be on this date. That happens a lot with IVs. So you could have a patient that you get the referral on Monday. The IV is not going to be started till Thursday. And the doctor has said, that's when I want you to admit the patient on Thursday. So because the doctor's order gives you a specific date, for the referral, then that becomes the date. And you have to admit the patient on that day, though. If Thursday comes, the expectation is that you've admitted that patient, unless for whatever reason you've called the doctor and said the patient, well, generally it's the patient. The patient says, don't come on Thursday. We're going to start on Friday, or something happens and the patient says, either for some medical reason.
Okay. If something happens that's not something that the PCP intended, the PCP intended that the start of care should happen on Thursday, but the patient says, no, I am not in a position to entertain anybody coming to my house, even though you're taking care of me, but I would rather, do it on Friday. There may be a reason. Then in that case, a home health agency gets dinged because...
No, they don't. No, they don't get dinged because of that. They don't get dinged. But what they have to do is they have to call the doctor and then explain to the doctor, and the doctor has to say, all right, you have to, Friday's fine. And they always say it's fine because, if the patient's refusing, the patient's refusing. You document that telephone call. So now you have in essence, you have a verbal order to start the next day, right? You would get dinged if you didn't call the doctor. If the patient says, don't come until Friday, and you don't notify the doctor's order still stands then. The doctor's order was Thursday. You didn't follow the doctor's order, right? So that would be a problem.
You can have a verbal order for a delayed start of care.
You can.
I've seen that with some of our customers. Right. That's how they do it. Make a voice call and, make that happen. So
you cannot delay it because you don't have staffing. Let's say something happens.
That's a valid reason.
Right. So you can't, if your staffing doesn't work out and you don't have staffing, you will get dinged for that because Medicare says you accepted the patient. You knew you had to see the patient within 48 hours, or you knew you had to see this patient on this day. Not having enough staffing is your problem. And so that would be a ding. But if it's a physician ordered start date that is different than that 48 hours, or if the patient refuses. And so let's say you're going to see the patient within that 48 hours. You're going to see the patient on Wednesday and you call the patient and they go, oh no, Wednesday's a bad day. Come on Thursday. Well, you call the doctor, you get the start of care changed to Thursday, and then you see that patient. Now, sometimes the patient says, oh, I thought Thursday was going to be good and it's really not. Come on Friday. And so then you have to call the doctor again. And you have to get another order to change the start of care to the Friday. If you do all those steps, then you're within compliance and you're not going to get dinged. So your timely initiation of care really has to do with either the regulation standard, the regulatory standard of within 48 hours, or meeting the doctor's order. So those are the two things that they're really looking at for timely initiation of care. And it's within 48 hours. So let's say let's say you get the patient, you get the order this morning and it's an afternoon IV. Well, you have to go, you're going to go today, even though same day referrals or starts of care, you try not to do that. Or if it has to be done tomorrow because they're on a vac for their wound, or they have a wound care dressing in RIV, or some critical reason why they can't go 48 hours without being seen. So it's up to 48 hours. It's not 48 hours. So I think that's right. So that's a clear distinction. So timely initiation of care is one element. And then
so these are two different things though, right? You mentioned one measure is the quality of patient care.
Wait, I'm not done. Yes. So let me finish with that because it's important. So then you're going to look at improvement in functional status. 3 to be specific. You're going to look at improvement in ambulation, improvement in bed transfer, and improvement in bathing. So you're going to score the patient at the beginning, your OASIS start of care. You're going to score the patient at the end when you discharge the patient. And the difference between the two is going to show an improvement in those 3 areas. And those, we're scoring the patient on every GG code, right? We're every functional thing. Those are the 3 they're really looking at to prove the patient improved. In addition, they're looking at improvement in dyspnea and improvement in oral medications. So those are the 7 elements that they look at in order to determine which star rating you're going to get for the quality of care that you provided. Those elements are what they're looking at to say, are you providing quality of care? Did you see the patient in a timely manner? Did the patient improve in these areas that we, the government, thinks are very, very important over the course of taking care of that patient? So that's what you're scored on. Now, what happens is that you send your data in, they collate that against every other home health agency and determine ranges for 1-star, 2-star, 3-star, 4-star, and 5-star. So you are comparing yourself to yourself, and you're also comparing yourself to all the other home health agencies. So and it's kind of a moving target. And so you look at the points you get, and that determines what score you get. So it's all, it's an algorithmic scoring thing that they do, but those are the data points. The other thing that happens is the patient satisfaction score. So what happens is that's
the second one. So
that's the second one.
All about the quality of patient care. And this next that you're going to talk about is
patient satisfaction.
Got it. So like patient survey driven method.
Right. So the federal government sends out surveys to approximately 10% of your home health population, because they know who your home health population is. And so, because you're submitting the bills, right? So they randomly choose 10% of your patient population, and they send out a standardized survey. Everybody gets the exact same survey. And then they look at, you don't have an obligation to return the survey as a patient. So if you answer and return it, that's great. And if you don't, they get the number of surveys they get, and your scores are based on however many surveys you get. So if only 2 people answered, that their medications were explained to them in a way they could understand, and only one said yes and one said no, then you only have a 50%. Then you have a score of 50%, which is really bad because it's only 2 people. So what you want to try and do is to make sure your N is high enough that the data it becomes relevant. So we're not allowed to tell patients in advance what the questions are going to be, but we really are able to tell patients that they may be getting a survey, and we encourage them to complete the survey, that we want to give the best care we can, but it's really important to us that you complete that survey so that we get feedback, because then I, as an agency, get feedback from the federal government. I get the surveys back. I get what each individual survey, how I was graded on each individual survey. I get the collated numbers of what where I sat, and then with all of them, what the N was, what the compliance was with each one of them. And then there's a place for patients to write comments. And so then I get a copy of all the comments. You guys were the best. I loved Linda. She was the best nurse in the world. And then we can utilize that to either improve patient care if it's a complaint, or we can use that to give attaboys to, our nurses or our PTs or whoever it's about. So it's a great tool for us. And the patient is asked things about when they called the office. Did they get a timely response? Did the nurse go over, and there's like 7 questions or more about their medications. Did the nurse talk to you about their medications? Did the nurse explain the desired effects of the medications? Did you have any, did your questions go unanswered? Could you get a hold of it on the agency? So there's questions about the agency. Did whoever answered the phone, were they nice, kind of thing, questions? And then there's questions about the care. Do you feel like you got really good care? And do you feel like your care improved under that you improved under their care? So it's a long survey. And it can be anonymous. You don't have to complete your name. So a lot of times we don't know, they don't put their name on it. So we don't know who they are. We just know that they're our patients. So the same thing happens. The federal government sends the surveys. The surveys go back to the federal government, and then they collate all that information, and then they give you a star rating based on how well you did. Now, it's a Likert scale for the patient, and the only numbers that on a 1 to 10, scale. The numbers that count as being a positive answer are the 9 and the 10. So if you say it was average, then that doesn't work towards a higher star score. So when you're looking at those scores, if you're a bunch of 8s, then you could still have a poor score because 9 and 10 are exceptional, right? Those are the highest, and that's what they're really looking at. They're looking at that the majority of the time, or either always or the majority of the time, the answer, yes, they did this. I understand my medications because of them. 9. They answered the phone in a manner that was pleasant, or whatever the question is. And the answer is 9 or a 10. Yes, really. A lot or all the time. So that's important to realize the way it's scored. Based on those two things, you get scores 1 to 5 stars.
Got
Everybody
it.
gets scored.
Got it. So now this could be like, okay, so let's take an example. If you have an agency that's like clinically excellent and they're getting great outcomes, and they're taking care of the patients are improving. However, let's say they're terrible at communication, and they would have high quality stars but very low survey stars. Or the reverse could be true as well. An agency that's warm and friendly but not actually getting the results. Have you seen that disconnect?
Yeah. Oh, yes. That's a very common disconnect, that their quality stars are high because they do the OASIS right, because they get in to see the patient. But their patient satisfaction scores are lower because they fall down on patient communication. Did you feel like one of the questions is, did you feel like your clinicians cared about you? Right. So all those things, did you feel like you had consistent care? So these are all so all the patient satisfaction things are the empathetic, emotional connections. Did you get your questions answered? And then specifically about, did someone ask you about pain? Did someone ask you about medications? And remember, these questions for many people are coming afterwards. So you may have, did your nurse, did your clinician assess the safety of your home? Well, we assess the safety of their home on the very first visit. But if the home is safe, we may not bring it up again. So by the time they get to the survey, they go, no, I don't think anybody assessed the safety of my home. And so we're busy going, yes, we did. Yes, we did. Right. So now we as an agency have to then figure out ways to remind the patient. So one of the ways we do it is on the discharge, we say, just want to remind you that we did these things with you. And remember on the first visit when we did the safety evaluation, remember that we talked about your side effects of your medications. Remember that. So you kind of go over everything. You go over everything because it's good for the patient to do that. But then you also do this.
So when would you be telling this? Like at the end of the episode, at the end of the billing period, 30 days, 60 days? Or what if it's a long-term?
Yeah.
When does the survey arrive, or we don't know?
No, we don't know. The survey comes when it comes. Once they get their first bill and they know you're a patient, then it could be while you're still on service. It could be after the first 30 days, right? It could be you've had the patient on for 6 months and they finally they come up and get a survey. Some patients never get surveys, right? Because it's a random sampling. But it's good practice to remind patients again, what you accomplished together. So
because it's important for the ratings, of course.
And it's important for the ratings. So you want to do that. So absolutely, you can be a wonderful, warm, empathetic agency that your patients all love, but your nurses don't know how to score the OASIS. They're having those problems we talked about before, where they're scoring them really high on admission, and so when they come to discharge, it looks like the patient didn't improve. And the other thing, though, it's important to realize is that the federal government throws out the zeros. So if a patient is a 0, meaning that they're completely independent in ambulation, and they're going to be, unless something bad happens, they can't improve because you scored them a 0. And the same thing if they're bedbound. If they're bedbound, they tend to, and there's no expectation for recovery from that bedbound status based on the diagnosis, then they'll throw the 5s out as well, because you shouldn't get dinged because the patient is bedbound and you didn't make the patient walk again. I mean, unless if they start off bedbound because they're, or ambulating at a certain level because of a long-term stroke and they're really not going to get better and you're there for something else, then you shouldn't. The federal government is trying to make sure you don't get dinged for stuff you shouldn't get dinged for, right? But if the patient comes with an ambulation score of 2, then they expect that you're going to get a 1 or a 0 by the time the patient's going to improve. Bathing. And what are they looking at? They're looking at bathing, ambulation, and transfers. So those are key areas. Dyspnea is a big thing. Did your interventions help give the patient tools so that they could decrease their dyspnea on exertion? They found compensation tools, right? And the same thing with medication management. We know that one of the main reasons for rehospitalization is medication noncompliance. So they want to see our patients improving in their medication adherence. So that's why they're looking at those things. And you can go either way. You can, if you're not good at your skills, if you're not good at your OASIS, your clinicians aren't documenting appropriately, it's going to look like the quality of care is not good. If your nurses are forgetting to document the phone calls to the doctor when the starts of care change, it looks like you're not doing timely interventions of care. When you may be, but they didn't document
quality ratings, right? Yeah.
Right. So they didn't.
Ratings, so there's only 2. So quality and the patient survey. And
right.
Quality ratings, anything to do with clinician, anything to do with the quality of care, improvement in the patient, and then the patient survey is how you treated them and the communication, and depends on the survey. Now,
right.
I want to understand how these ratings are used. So, I mean, because these ratings are public and anyone can see them.
Right.
But my question is, do they actually matter? How do hospitals and discharge planners use these ratings when they're deciding where to send the patient?
So, yes, they really do matter. We have referral bases that say if your star ratings fall below a 3, we're not going to refer to you. So we're not even going to look at you. If you're, and some discharge planners, even within the system, you may be our system, you may be the home care agency for our system, but if your star rating falls below a 3, then you're not going to be our first choice. Now, again, it's always up to the patient. So the case managers can't steer one way or the other. They have to ask the patient, do you have a preference in the home health agency? And if the patient says, no, I don't have a preference, then they will give you a list of agencies and that you can choose from. But they can give you, and we know the way people look at lists, they look at the top 5, right? Or the top 3. I mean, they don't go to the second page and look at the number 20 and say, give me that one. So generally what case managers do is they list them by star ratings. And so they're going to be listing the agencies that they have confidence in can give good care. And from a patient advocacy perspective, it just makes sense, because you want the patient to get discharged and get good care. You want them because you want the patient to get good care, but you don't want that patient to end up back in your hospital within 30 days because then the hospital gets stinged. You don't want to have a bad reputation. You don't want the patient to say, oh my gosh, they recommended that agency. It was so terrible, because now it reflects on the case managers. So it's like a win-win-win, right? It's like 3 different outcomes based on just the referral. So absolutely, being a 4-star agency or a 5-star agency is telling the world that you give really good care and patients like the care they get. Patients feel cared for, which is really kind of ultimately that they feel cared for. So yeah, they really make a difference, and you want to do that. And also remember, some of the things that you're getting scored with value-based purchasing are the same things that contribute to the star ratings. So they overlap. So ultimately, if you're getting high star ratings, you're probably doing well with value-based purchasing as well.
And I think that's something that we're going to get in a lot of depth in the coming sessions. No, that makes sense. And I think it's your overall rating of, do you have your stuff together?
Right.
So a hospital might have a preferred provider list as well, though. And if you're on that list, then in that case, do the stars matter? Because I hear a lot of times that hey, go out there and, sit at the emergency, room and go network with the people and take donuts. And I mean, for a lot of the salespeople, maybe not so much in home health because of all this demand and the complexity, but I know that in other fields like in home care or in hospice as well, there may be a little bit more of this type of, you know, a networking with the hospitals and stuff. So if you're not on that list, in order to get on that list, you need better ratings. And what happens if you're already on the list and your stars drop? Like you could be kicked off as well, I assume, because they may have some sort of a program that we, like you said, we only keep agencies with, ratings more than 3. So is 3 the average rating? I'm thinking, okay, got it. So 3 is an average rating. Either you're above 3 or below 3. And if you're below 3, then looks like you're not doing as well in terms of comparing with your own self in the past and also comparing with other similar agencies.
Right.
And like you said, this also connects with the value-based purchasing. And, we've covered that a little bit, but we're going to do a deeper dive on that later on. So looks like then star ratings have real financial consequences too.
They absolutely they can. They absolutely can. And also it's also a bragging right. It's also a synopsis, like you said, of your whole agency. So to be able to say I'm a 4-star agency or I'm a 5-star agency is quantifying the statement that you say, which is we give excellent care and our patients love us. So if you say we give excellent care and our patients love us, and I say, what's your star rating? And you go, well, it's 2 for quality and, 1 for satisfaction. Then I'm going to say, yeah, that obviously the first statement doesn't match the second statement. Right. So, I think that is a way to level the playing field, and it really does. And if you're a savvy consumer, or if your mother,
what about the patients and the families as a consumer? Are you really going to Care Compare and looking at it, or tell me about that?
Well, some do. Some go to Care Compare and they say, I live in, you live in if you live in a larger metropolitan area where the choices are much more significant and you've had a bad experience, you might want to say, well, who else is out there? Who else can we use? And then you use that just like you would use any, we do the same thing for our hotels and we do the same thing for our restaurants. We have all those reviews and the star ratings and everything else. And there are people that'll look and do that, because ultimately the choice of the home health agency is up to the consumer. Ultimately, that's the way the regulations are written, that I, as a consumer, choose. The reality is that most of the time, if you haven't been part of a home health system or you haven't been in that part of the transitions to care before, you don't know. You don't. And most of the time you're in the hospital because something happened and your doctor said you're going to this hospital, or an emergency happened and that was the closest hospital. So somebody is now saying to you, where do you want to go? And you're like, oh, I have a choice. Oh, okay. Well, let me, and then inevitably they say, well, what do you recommend? If they don't. And if they've come from Sarin VNA, they'll say, well, I was at Sarin VNA. I want to go back there. Or I was at Sarin VNA and I do not want to go back there. So, find me somewhere else. But if they don't have that experience, they will invariably say to the case manager, what do you suggest? And then out comes the paper and then you pick them.
Got it. And what I found fascinating as I was researching about this was that, see, a lot of these portals, like I think the most popular one might be within Epic. A lot of the hospitals just send it through Epic, and okay, you're going to get a new referral through Epic. You may get an email, or you may even be communicating with a case manager, but you go log into your Epic portal, and different hospitals may have, like we have Epic Hartley and Epic this, and, there may be different names of those hospitals. But then there are these other ones, like there were startups that got bought, like by Bellsky, a lot of them. So there's CarePort and Allscripts, and then there's other ones too, like Dina, Episodic. But there's one that is very unique. They're called Aiden. And what I heard was that the way that they are doing it is they partner with the hospitals And it's actually the patient who is shown, just like how you described, a list of all the home health agencies, but they're shown on an iPad and they have a representative and they don't have a dog in the hunt. They're just saying, patient, you pick the best one. And they give you not just the star ratings, but also an opportunity for the home health agency to put a couple of pictures and describe the story, why they do what they do. So I feel like, it's a really unique model. I mean, they're not growing exponentially or anything, but they're growing. So I've seen that really works, well, and it goes with what you mentioned. The CMS is trying to preserve that choice for the consumer. So I think it's definitely going, in that right direction as newer companies are coming up.
Mm-hmm. Great.
Next, I'd love to, sort of segue into surveys, because this is the part that seems to stress agency owners out like more than almost anything else. And a state survey shows up at your agency, then walk me through what happens then, and like what are they looking for, how long does it take, and what's sort of the mood in the building, and what are the different types of surveyors as well, because I know there's the state surveyor and there may be other ones. I've heard of OIG, and so whatever we can discuss here.
Not OIG. That's the Office of the Inspector General. If you're having an OIG survey, you are in big trouble. That's a bad thing. But you will get a CMS survey. They call them state surveys, but it's really the federal government. What the CMS does, what the federal government does, CMS, the Medicare program does, is they contract with the state to provide surveyors within the state. So it is a state survey, but it's a federal survey. They're surveying compliance with the federal regulations for home health agencies. So just that little bit of clarification. But the state surveyor is going to come at least every 3 years. And whether it's announced or not announced, is going to be based on the state. I'm in Massachusetts and they're unannounced. One day you kind of know when they're going to come because they're about every 3 years because you're on a schedule, right? For the state, every home health agency is on some sort of schedule unless something happens. We'll talk about those surveys in a minute, but let's say it's a regular survey but you don't know. You kind of know, but you don't really know. And so then what happens, the first thing that happens is their surveyor, walks up and is at your front door, or is let in, and they say, hi, I'm from this, they give you their name, they give you their badge, their credentials, and they say, I'm from the state and I'm here to do a state survey. Immediate panic sets in with everyone. And the very next thing that happens is the director of nurses and the administrator are called. Then everyone knows that's what they have to do. Don't let them go anywhere else. Have them wait in the lobby because they're starting to look at everything, right? So have them sit in the lobby and wait. And then call the director of nurses, call the head administrator, CEO, or whoever it is, the administrator, depends on how big or small your agency is, right? And then let them know. And then if they are not in the office, because, you could be away at a conference, you could be at a doctor's appointment, you have no idea when they're coming, right? Then you are either in the office and say, okay, I'll be right out, and you take over, or you say, okay, get a hold of Arvind, because Arvind's the clinical manager. Arvind knows what to do. I will be there in however long you're going to be there. So that's the very first thing that happened is there's a protocol that everyone knows, from the person who is at the front desk, who answers the front door, all the way through. Everyone knows what to do if a surveyor comes. Then what you do is you ask them if they want coffee and all that stuff. But what you then really do is you find a secure area that they can work in and not be disturbed. And usually it's a side office or something like that that's not really used, because they have a job to do and you don't want them to be in the middle of all the stuff, all the noise and confusion and everything. And don't forget, they're also looking at everything. So you want to kind of control the environment that they're going to be sitting in. You know that they're there to do an audit of your clinical functioning and your operational functioning. So everyone knows that. So there's certain manuals that you pull There's certain information that you're going to need to do. You run a patient list because they're going to do that. You know that they're going to probably come with certain patients based on billing that they're going to want to look at because they're going to do chart audits. Then they're also going to want to have you give them a list of patients, and they will tell you sometimes, I want to see these patients that have this diagnosis that are on active service. I want to see these number of patients that are discharged. So they will give you the parameters for the patient review and the patient audit. They will do home visits. So they're going to tell you from the charts that they're ordering of the patients that are actively on service, who they want to go see.
Actually go to patients' home during the
Yes.
survey?
Yes.
So they're not just looking for your paperwork, but they're watching nurses in action.
Absolutely. So they're going to say that. And so they're going to get the first day. They're usually there about, depending again, how big your agency is, they're usually there about 2.5 to 3 days. So, and if everything's going well, it's a good survey, then they're there for 2.5 to 3 days. And then that first day, that's what they're doing. They're setting everything up. You're giving them all the information that they're going to need based on the parameters that they've told you what they want to look at, right? They're going to want to look at personnel files. They're going to want to look at a certain number of personnel files, home health aides, PTs, OTs, nurses. They're going to want to look at the personnel files of the people that they're going to be going to see patients with. So they're going to choose the patients. They're going to tell you, I want to see patients on this day. And usually it's the second day. They want to go do home visits. And they'll tell you how many home visits they want to do. And it's based on how large your agency is. So, cause it's all based on the end, right? So it's all based on how big your agency is. If you have 200
they
people,
pick the patient, or do we get to choose that?
Oh no, they pick the patients. They choose the patients. They choose the patients. So, and then what they'll do is they'll say, we'd like to go see these patients. Now, the home health agency has to call the patients and make sure it's okay that they come.
Okay.
Right. It has to be
not during the visit. Like,
yes.
Okay. So they would say that, okay, when is your next appointment? Okay, I'm going to just follow along with Nurse Sally to Mrs. Smith.
I want to see these patients. And we could say, well, this patient only has you're here Wednesday, Thursday, Friday. And because they're assuming that these patients are sick enough, you're seeing them more than once a week, right? If you say, well, this is a Foley catheter patient, they'll go, oh no, never mind. I don't want that patient. Give me somebody else. So they're figuring that they're going to be able to see that patient. If for whatever reason they can't, then they'll find another patient. But you have to ask the patient, because remember, we're guests in their home. They have authorized us as the home health agency to come into their home under HIPAA guidelines. But they haven't authorized whoever we want to come in the home to come in the home. So we have to call and tell them that we're having a survey, tell them that it really is fine. The survey is not to evaluate whether they should be getting service or not, because patients think, oh no, they're going to tell me I can't have the care. So we have to be very careful and tell them that's not what they're doing. They're looking at us to see what kind of care we are giving you. You are getting the care. Don't worry about that. So then people usually relax. And I think I've had maybe once or twice a patient has said, no, I don't want them in my home. But most of the time, patients are like, sure, that's okay, fine, they can come. They'll come with their nurse, and it's usually, they're going to be coming with Kathy, and Kathy's just going to be doing your normal visit. And this person is going to be watching Kathy. And so then they're like, okay, that's good. And usually they're really nice and really, oh, she's so wonderful. Kathy's so wonderful. And everything, because they're trying to make sure that they get a good impression. And they'll, depending on what they're looking at or looking for, they're going to pick those patients. They may say, I want to see this patient. I want to see a wound care patient. So we need to make sure that we can get a wound care.
They have done their homework and said, oh, these OSS charts look like they don't have a lot of explanation, or they're looking very cookie cutter. So let's go to this patient. Or is it really kind of random? They haven't looked at the chart audits yet. So they're basically looking at the sheets, and they're looking at maybe what the previous billing was. They may be looking at this. They may be looking at severity codes, the PDGMs, and those kind of things. Yes, absolutely. But they're not actually looking at the OASIS itself at that point. Then what they'll do is, before they go to the patients, they'll schedule the patients. Before they go to the patients, now they're going to do a chart review. They're going to really evaluate the chart and see what's going on. Because now they're going to say, this is what all the documentation shows. I'm walking in the patient's house. Does it match?
right? So they're going to
Absolutely.
be looking at that. The other thing is remember, we have infection control procedures that we must follow. So they're going to be looking at the nurse's bag technique. They're going to be looking at their infection control technique. Are they washing their hands? Are they wearing gloves appropriately? All those things that we have to do. Bag technique is a big deal. So they're going to be looking at it in the patient's home. They're going to
So
be
bag technique is like putting the soiled stuff in
in the
one and one.
soil, making sure the bag doesn't just sit on that. There's a barrier between the bag and, wherever you're putting that, you're putting it on a hard surface. You're not putting it on the floor, those kind of things that we all know you're not supposed to do. And they're looking at the patient's home environment now because they've read the document, they've read the chart, they have in their head what they think they're going to be looking for and looking at, and they're getting it to the home to say, does that match what they've read? They're going to be reading many more charts than just those 5 of the home care visits they did. But they're going to be looking at that. They're going to be looking at your documentation. Does your documentation support the care you're providing? Did you get in timely initiation of care? They're going to be ticking off all those things, right? And if you didn't get in there in a timely manner, do you have the documentation to support it? All those kind of things that we know that you need to do. They're going to be looking at documentation for communication, coordination, all the regulations. Did you show coordination of care? Did you talk to all the doctors you're supposed to? Did you do multidisciplinary conferences the way you're supposed to? All those processes.
This could happen, like this happens once in 3 years.
Mm-hmm.
So are they able to go back to look at the data for the last 3 years, or they just focus on the last billing, like you said?
So they absolutely could go back and say, discharge patients 2 years ago. I want to see what you did. They don't tend to do that. They could do that, but they don't tend to do that. They tend to look at what's going on now. Now, if they find that everything is fabulous, they look at all your operations. You say the home health aides have 12 hours of in-services a year. I've got an aide who's been here 5 years. Have you done those 12 hours every year? So when you're looking at your personnel files, they're going to say they don't want somebody who just came. They want to look at people who have been on for a while, and are you compliant with all the stuff that you're supposed to do from real regulatory perspective? Are you doing your QA meetings? You're supposed to have quarterly QA meetings. Did you do them? What did you do with the information you got? So all of those operational things that we have to do, they want to make sure that you did them, and then they want to see your policy manual. So then they may go in your policy manual and say, well, your policy says you do it 6 times a year, but you only have documentation for 3 times a year. So you're out of compliance with your own policies. And that would be a ding, because you have to be in compliance with your own policies. Wow. So if everything goes well, at the end of 3 days, they do an exit interview and they say, you were fabulous. You have no deficiencies, which means that everything was exactly what it's supposed to do. You might have a standard level deficiency where there were a couple things that you didn't do right, but it didn't rise to a higher level of deficiency, so that you can still just fix these things, and you've got 60 days. Tell us what you're going to do, blah, 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 but we're done here. So because you weren't perfect, but nothing rose to the level of now we have a problem with what you're doing. So give us your action plan, what you're going to do. Give us the timeline for, you have 30 days to turn it in or 60 days to turn it in. I can't remember what it is now. And then you then say, I'm going to do this within this period of time. And then you need to let them know that you did it. So it all then becomes paperwork, right? How are you going to fix the stuff that they found? If things don't go well, they will tell you, usually before the exit interview, that they have found some significant problems. And so they're going to be doing an extended survey. And so when you get to, a condition level survey, because it's just, so we talked about care plans. I think we talked about care plans, right? And you have got the problem and they got the goal, and then you got all these interventions. Well, surveys are the same thing. You've got the condition that you need to meet, and then you have all these little subsections of all little things that have to be met in order for the condition to be met. Now, you can have 1 or 2 standards that are out of compliance, but you're still basically in compliance with the condition. So these are standard level deficiencies. These are the ones that just get the paperwork done. you have to fix it, but you can do that. If you rise to the level of condition level deficiency, that means that you're not meeting a condition that is essential for you to meet, because they're all essential for you to meet. So now we're going to extend the survey. So now we're going to spend more days, and we're going to look at more charts, and we're going to look at more processes, and we're going to see if it really is a big problem, or the more we look at it, the problem shrinks because it was just that segment. If you're at a condition level deficiency that is serious and it shows a pattern of issues and a pattern of problems, ongoing problems that you need to correct, and you will then have a timeline for correction. You may come back and have another survey, another audit. If your survey finds that you have significant condition level deficiencies, then you can be in what's called immediate jeopardy. And that means that you have a finite period of time, usually about 20, less than a month, but period of time to fix that. And they'll say, we'll be back in 30 days. We'll be back in 25 days, whatever one of those things. They'll tell you that, and they'll say, this has to be corrected. You have to have a plan of correction that we see you've put in place within this period of time. If you don't put your plan of correction in place and essentially turn it around, we're going to close you. So if you're in immediate jeopardy, you have a finite time to fix the problems, and because they believe that they are significant problems. If you have a finite period of time to fix the problems, and if you don't fix those problems within that finite period of time, they will close your agency. So it goes from you're perfect to you not meeting some of the standards, but we're going to give you time to fix this. Send us the paperwork that shows you did, and we're going to assume everything's going to be fine, to a condition level deficiency, which is a higher problem and is more severe. And they may need to come back in 60 days and make sure that you're okay, depending on what the condition level was. They will determine what you have to do to prove that you're in compliance now. And then immediate jeopardy means that you are so badly out of compliance that we think that you could be jeopardizing patient care. And so you have 30 days, 25 days to get this fixed. And they'll tell you exactly how many days. Sometimes it's 10 days. I mean, they can determine just how bad it is and how fast you have to turn it around. And if you don't do it, if you can't be in compliance, then they'll close your agency. Well, they don't close your agency. You lose your Medicare certification. And if you're not certified for home Medicare for home care, then pretty much you might as well, because then you're going to lose your Medicaid certification. You don't have to worry about star ratings, because everyone will know that you've been decertified. No one's going to refer to you because you're decertified. So it's a huge deal.
Wow. And that's just the standard survey. And I've heard there are other ones too, like the complaint-based survey.
Now, complaint survey, though, is a very focused survey. So what happens is that someone complains about you. They complain about the care. And the surveyor comes in and says, we've received a complaint. This patient has complained, and this is what the complaint is. So they will review the patient chart to see is a legitimate complaint or not. If they find that you really didn't do anything wrong, you really weren't at risk, right? The patient wasn't happy, but it wasn't because of negligence on your part, then you're done. They go, okay, well, we reviewed it. We didn't find that there was a problem. Thank you very much. They do their paperwork. They're done. However, if they get into the chart and they think that there could be a bigger problem, then they will put on their surveyor hat and say, okay, we're moving from a complaint to a full-blown survey. So they could easily say this complaint is justified and it reflects a bigger problem in your agency. So now I'm going to sit here for 3 days and do a survey. So now you're in the middle of a survey, and then you have to, right. And then and what you have to do to fix it is called your plan of correction. And it's very standardized, and there's forms that you have to fill out, and you have to meet the criteria and everything else. So,
Got
And
it.
then it gets reviewed, and the state then has a certain number of days to review it. And then they have to communicate and say, yes, we accept your plan of correction. Or they say, no, we're not going to accept this. These are the part, either not the whole thing, or these are the parts we're not going to accept. You have to try it again and send it back to us again. Right. Most people know how to do that. So doing the plan of correction is something that you know how to do and hope you never have to. A lot of the deficiencies are, well, there's low hanging fruit deficiencies. So generally, bag protocols tend to be a challenge because the nurses have to remember their bag technique. And all you need is one nurse that doesn't do exactly the right thing, and you could be in a standard level deficiency. So that could be a problem. There's a requirement that home health aides are supervised every 14 days. So they'll count the days. And if you have 2 patients that they were seen on the 15th day or the 16th day, then you're out of compliance. So some of them are the ones that tend to get you are the process ones, because those are the things that, somebody screwed up and they didn't schedule the aid right within that 14-day period. So we do things to try and prevent that from ever happening. You might have a plan of care that is missing elements that need to be there. That doesn't happen as much as it used to, because now with the electronic EMR, they take the information and they fill it all out. But what does happen is that it may be incomplete or it may be wrong. So the plan of care could say that the patient has equipment in the home they don't have in the home.
Mm.
Right? Or you could not put the wound care supplies on the form, and you have to do that. So again, you're not completing the form appropriately, and they'll say that's not appropriate. The nurse has to date and sign when she got the verbal order, so that better match the verbal order that you got at the start of care. Those dates better match. If they don't match, then that's a problem. And it's under the G574 requirement, because they're missing data elements, but it could be as simple as the dates are off, right? So that's a standard, and you could have a problem with that. The plan of care may not be individualized. If they read 10 charts and they say all exactly the same thing, then that's a compliance issue, because you have to individualize the plan of care.
Yeah. And this connects back to the documentation burden theme,
Exactly right. And they are documentation things. They're like the verbal orders weren't handled appropriately, or you didn't get them. So you didn't send out doctor's orders for signature after you got the verbal orders. There was a breakdown in the process. And again, the quality programs say we're going to do it this many times and you don't do it. So those kind of things are the ones that tend to be the general ones. And if you've been in home care long enough, you're pretty much know where the potential issues are going to be. So you build processes in to make sure that you don't get caught by the stuff. It's like not doing the home health aid visit every 14 days is like, come on, we should never have a problem with this. So why are we having a problem with this? And so you want to make sure that you have things that are built in, that you say, these are things that are easy to take care of, and make sure we have the checks and balances to fix them. Documentation issues are huge. Documentation doesn't show skilled need over and over and over again. That's a big problem, right? And that's a condition that you're providing skilled care. And the challenge is if that you don't want incompetence to look like fraud. So sometimes it's just incompetence, but if it happens over and over and over again, it can look like you're trying to defraud the federal government when you're really not trying to defraud them. You're just incompetent. And so we have to put checks and balances into place for that too. I was new to a home health agency, and I had just started as their director of nurses. And so I inherited the agency. And when you're new, you live with what was coming before as you're busy trying to improve things. And the surveyor walked in, and we ended up with several condition level deficiencies. Now they were right. There were issues that needed to be fixed. But then what I was able to do was to turn the agency around And the next survey that came was 2 years later, and I'd been there for a while. And we went from condition level deficiencies to deficiency free surveys. And that was, but it was a lot of work. It was a lot of hard work. It was changing a lot of processes, letting some nurses go that just really could not come up to the standard of care that became the expectation for that. But it was a really good feeling to realize that we could, with a lot of hard work, go from an agency that had a lot of challenges to a deficiency-free survey agency. So I think that when you're in the middle of it and you're realizing how bad it really is, and you didn't have anything to do with it, but you are responsible for it because now you're the director of nurses. It's a terrible position to be in, and your throat is in your, how does it go? Your heart is in your throat and your stomach feels bad. And then you have to just say, well, I didn't make the problem, but it's my job to fix the problem. So, then to be able to take it to a deficiency free survey was a huge accomplishment, for the entire organization to work together to make that happen.
So let me summarize what we've covered today. Looks like we have two types of star ratings on Medicare Care Compare. Quality of patient care stars, measuring clinical outcomes. Did the patients improve? Did they stay out of the hospital? Patient survey stars measure more of experience. Did the patient feel cared for? Would they recommend the agency? An agency can be strong in one and can be weak in other. These ratings matter because they affect referrals, value-based purchasing payments, and your reputation. Discharge planners may use them to decide where to send the patients. Families may check it to choose which agency to send their loved ones to. Behind the ratings is a survey process that can be stressful and high stakes. Surveys review records, visit patients, and look at every compliance type of item included in the conditions of participation, the COPs. When they find problems, they cite deficiencies, and most of those deficiencies come back to documentation. The plan of care wasn't complete, or the verbal orders weren't handed correctly. The clinical notes didn't tell the full story at times. And if the problems are serious enough, immediate jeopardy. The agency has 23 days to fix it or face termination from Medicare. That's the stakes. Once again, we see the documentation burden at the center of everything. It drives the staffing crisis. It drives survey deficiencies. It drives quality scores. If we can solve documentation, we solve a lot of problems. Next time, we're going to tackle a topic that's changing everything in home health: Medicare Advantage. More than half of Medicare beneficiaries are now in MA plans, and that shift is creating huge challenges for agencies. Prior authorizations, lower reimbursement, longer payment cycles. Kathy has a lot to say about that one. Kathy, thank you. This was really helpful for understanding how quality systems work. Thank you, everyone, for watching. And if you're an agency owner preparing for a survey, I hope this helped you understand what you're facing. See you next time on Inside Home Health. Goodbye.
Thank you. Bye-bye.